This is a presentation on the relationship between tethered oral tissues and pediatric sleep apnea syndrome based on the pilot research study, Incidence of Obstructive Sleep Apnea Syndrome and Tongue Ties in Children. Ankyloglossia is better known for its lay term tongue tie. It is also referred to as a sublingual tether, tethered oral tissues, and frenulum. Ankyloglossia is the abnormal vestigial remnant or leftover tissue that connects the tongue to the floor of the mouth. This abnormality results from incorrect apoptosis, the natural termination of cells. The remaining tissue restricts tongue movement and mobility, limiting the subject's ability to perform many oral-related tasks. Providers who frequently encounter ankyloglossia patients include dentists, orthodontists, tethered oral tissue specialists, and breastfeeding lactation consultants. This is due to the symptom of painful breastfeeding that some mothers experience. The pain is secondary to compensated suckling mechanics that the infant or child resorts to when normal suckling mechanics are immature due to an anchored tongue. The normal mobile tongue creates constant pressure against the walls and inside of the mouth to expand dentition. Failure to do so results in malocclusion and a high-arched palate. Secondary signs of ankyloglossia include oral breathing, enlarged tonsils and adenoids, difficulty with speaking or pronunciation, or the inability to concentrate or difficulty sleeping. Ankyloglossia is graded or classed into 4 subgroups. Class 1 through Class 4, Class 1 representing the least of oral tethers, and Class 4 representing the most severe cases. A tongue tie is determined by measuring from the tip of the tongue to the point of insertion of sublingual tissue, or where the frenulum begins. When the tip of the tongue to the frenulum insertion point measures less than 10 millimeters, it is considered a tongue tie. From 4 to 6 millimeters, the tongue tie is considered moderate, and 0 to 3 millimeters is considered severe or a complete tongue tie. This system was devised by Dr. Lawrence Kotlow to begin evaluating tongue tie severity. There are other examinations performed to scale tongue tie severity. However, the Kotlow method is an uncomplicated and frequently used diagnostic tool. Here you can see classes 1 through 4 from left to right respectively. In the next slide, these pictures are marked to reflect the tongue tie. However, it is plain to see that the upper and lower jaws are open to the maximum mobility and form 2 lines between each mouth to show the oral space is relatively equal. Of note, in the 3rd class, the classic heart-shaped tip is seen on the tongue. It's a common sign of ankyloglossia. Here, the maximum protrusion upward is represented with the yellow circle. The blue lines reflect the untethered region of the base of the tongue. As the classes increase in severity, the blue portion decreases and disappears in the 4th class. The red lines indicate the length of the oral tether. Several studies have shown commonalities between obstructive sleep apnea syndrome and oral tethers. Most recently, at least 2 studies have directly correlated obstructive sleep apnea syndrome with an oral tether. Other studies have demonstrated the effect oral tethers can have upon a person, such as malocclusion, craniofacial morphology dysfunction, and epiglottal and larynx displacement due to genetic ankyloglossia. Several other studies were used in this process to determine other likely causes of adenotonsillectomy, as this is the first-line treatment for pediatric obstructive sleep apnea syndrome. All articles reviewed admitted that tonsil and adenoidectomy were inadequate to be a cure for obstructive sleep apnea syndrome, but that they showed that the anatomy is associated. This study used information gathered from a professional who encounters pediatric ankylosing patients in a clinic. These patients are primarily seen for breastfeeding purposes, but the preliminary examination is quite extensive. Like many other providers, sleep screening is used. The 3 questions listed in this examination included: does your child snore more than 50% of the time they sleep? Does your child breathe orally when they sleep? Have you witnessed your child trying to breathe but appears to be unable to move air in and out through the nose or mouth? The responses given were limited to yes, no, or not sure. The University of North Carolina Chapel Hill Institutional Review Board reviewed this study process and deemed it to be exempt to collect data from a provider based upon previous examinations. No personal identifying information was collected, nor could the project records collected be re-identified through any of the information taken. This is a sample directly from the examination survey of Dr. Ray Singh that he uses in his Tethered oral tissues lab. This is the exact copy that all the parents or guardians were asked to answer before being considered for a tongue tie in his office. This data was collected and sorted into an access database for easy manipulation. 5 records were set aside for a sample group as they were not diagnosed with tongue ties and they were dental patients. No subjects that responded reported previous obstructive sleep apnea diagnoses or an exclusionary disorder such as dwarfism, Down syndrome, or any other disorder that affects the shape of the mouth or face. The majority of the subjects were between the ages of 0 years old, or infants, and to 3 years old, the primary demographic for the original project idea. Males and females were off of even by 4, giving the demographic a slightly female dominance. 2 subjects were diagnosed with a mild tongue tie, 10 were diagnosed with a moderate tongue tie, and 8 were diagnosed with a severe tongue tie. The median and mode severity were moderate. 2 out of the 20 subjects, or 10%, reported snoring at least half of the night or sleep time. 3 subjects, or at least 15%, were unsure of snoring, and 75% reported no snoring. This question was somewhat controversial, as 50% is a relatively high value. For instance, a patient could have obstruction and snoring while they are supine, but not in the lateral recumbent position. That means the not sure and some of the no responses could very well represent snoring. If the patient sleeps 75% on the right lateral position and 25% of the night supine, it will not qualify for a positive response to this question. Severity and volume of snoring and position while snoring was considered but left out for simplicity. However, this study sought conclusive evidence for obstruction and leaned on the side of caution. 9 out of the subjects, or 45%, were positive for oral breathing while sleeping. 7 or 35% said no, and 4% or 20% were unsure. Again, the unsure responses adds an expectation that it is possible, but not for this particular study. Oral breathing is significant due to the susceptibility of the oral airway route collapsing easier than the nasal airway route, and it is also commonly associated with both tethered oral tissues and obstructive sleep apnea syndrome. 4 subjects, or 20%, reported observed witness apneas, while 80% reported no. This question was carefully worded to reflect that it appeared the child was attempting to breathe, observed effort, and was able to transfer air in and out of the nose or mouth. Witnessed apneas can be a controversial subjective item, and we wanted to be clear in what we were asking. Witnessed apneas could mean obstructive or central, and adding the added wording attempts to circumvent that problem, as some central pauses in breathing while sleeping is biologically normal, whereas obstruction is not. Probably the most significant result from this data set is that 55% of patients reported at least one obstructive sleep apnea syndrome symptom out of the 3 listed, and 36% of those patients, or 20% of the total cohort, reported 2 symptoms. Previously, it was expected that older children manifested symptoms of obstructive sleep apnea syndrome because of the ongoing abnormal development of craniofacial features due to ankylosing. However, this data suggests that obstructive sleep apnea syndrome symptoms may be seen in young children and infants. Oral breathing was the overwhelming symptom seen, but snoring and witnessed apneas were also reported. In the small control group of 5 dental patients without an ankylosing diagnosis and confirmed through examination, only 1 subject out of 5 reported snoring. There were no other obstructive sleep apnea syndrome symptoms, obstructive sleep apnea diagnoses, or exclusions listed. No obvious correlation between severity, age, or biological sex was drawn with the tethers. This data, as does other similar research, suggests an association of obstructive sleep apnea syndrome and tethered oral tissues. Logically, early intervention via frenectomy is hypothesized to prevent further abnormal development of the mouth, the face, and the airway. Further studies regarding obstructive sleep apnea syndrome symptoms status post-frenectomy should be performed. The pertinent questions remain: does an early intervention frenectomy prevent childhood or adulthood sleep apnea? And could frenectomy lessen or eliminate the need for adenotonsillectomy for obstructive sleep apnea syndrome reasons? Dr. Mary Ellen Wells was the advisor for this project, and I want to thank her for her educational expertise and moral support throughout the process. And I'll never be able to thank Dr. Racing for his patience and his kindness to allow me to come into his office, and he takes on risk when he does this. And I'm very appreciative to him and his team for that.